Thanks, James, for your introduction. So, ladies and gentlemen, welcome to EEG World. So, today I'd like to talk about the continuous EEG in daily routine indication, interpretation, and improved patient outcome. I want to show our experience of newer EEG, CerebAair. So, this is my COI. So, briefly, I will introduce my hospital. My hospital was located in Saitama near Tokyo. We are especially focusing on the emergent disorders such as stroke and traumatic brain injury and epileptics. Asaka Central General Hospital. Our member consists of 4 neurosurgeons and neuropsychiatrists and neurointensivists and fellow and paramedics. So originally, our ICU continuous EEG monitoring oriented from epilepsy surgery epilepsy monitoring unit. I used to be epilepsy fellow in Cleveland Clinic, United States. After coming back to Japan, we started epilepsy monitoring unit for pre-surgical evaluation. Since 2013, we just started continuous EEG monitoring in ICU as well as stroke care unit. So why do we monitor bedside EEG monitoring in ICU? The answer is to detect non-convulsive status epilepsy. That would be the best and strong reason. The other is to monitor the unexplained disturbance of consciousness after stroke and traumatic brain injury, and also post-cardiac arrest syndrome, PCAF, and delayed cerebral ischemia after subarachnoid hemorrhage. So why non-convulsive status epilepsy is so important? When a patient is transported in unconsciousness state and become hospitalized in the ICU, EEG are most important as an assessment of the cause of their consciousness disturbance. So I think NCSE is partly hidden in part. So it is said Okay.
Which slide? This one?
Okay, thank you. So as you already know, the non-convulsive status epilepticus seems to be accounted for a percentage of from 20 to half of all the status epileptics. And the other report said it accounted for a percentage of 8 to 20% of all the ICU patients. So at the beginning, we do a 10-20 electrode placement, and it had been conducted. It usually takes 40 to 60 minutes using for installation using corrosion, like this way. Then these are our EEG tech. So we would like to do EEG in ICU more frequently, but however, the problem is that the EEG technicians are so limited and to developing a successful program. So we just have 5 to 6 EEG tech in my hospital. So they divided into the 2 groups. One team is doing the out clinic from the morning until afternoon. The other group doing the epilepsy monitoring unit and analyze the EEG. But they are working well. But actually, they work just daytime. So after 5 p.m. to next 8 a.m., no EEG technician in my hospital. So what do we solve this situation? And of course, you know the extraordinary things happen at night. So how should we solve this problem? Then, from this January, we have introduced new EEG, CerebAair. So this CerebAair has caused a revolution in my hospital. So easy to install anytime, anywhere, by anyone. Even though after craniotomy, After craniotomy or TBI with very huge wound, it can be monitored. And wireless does not disturb various intervention in ICU and vice versa. So after coming up CerebAair, nowadays our nurse, fellow, as well as even me, are easily able to attach. So here, I will show the video, so actual video. So here, I will show you actual apply of CerebAair. So it's easy, really easy. So one nurse is lifting up the patient head because the patient head is very heavy because of the unconsciousness state, right? And keeping the patient head just 5 minutes. And then because other nurse is try to apply CerebAair like this way, it's very easy. So totally it takes within 5 minutes. That's it. Then check the impedance of the electrode and then start monitoring. Probably she just did several times, 2 or 3 times. Then nowadays she can do by herself. So in Japan, the EEG tech is very limited. So that's why our solution is rely on the nurse's work. Okay. So after setting CerebAair, you may see the patient after even the craniotomy. We take the gauze and put on the CerebAair like this way. Then monitoring has been started. So now next we're going to talk about the EEG morphology. How do we diagnose non-convulsive status epileptics? So diagnosis of NCSE are based on 2 important reports. So one is about morphology, reported in 2012, American Clinical Neurophysiology Society, critical care terminology was referred. The other is about diagnosis. It's modified Salzburg consensus criteria for non-convulsive status epileptics. That 2 reports could be important to diagnose NCSE. In ACNS, neurocritical care terminology, spike and wave defined as spike and wave with no interdischarge interval, like this way. Then periodic discharge defined discharge with interval, like this way. Then RDA is rhythmic slow activity with no interdischarge interval. This 3 patterns is very important in neurocritical care. So as you may know, SW and the PDs and RDA are classified under SW is especially highly related to the status epileptics. And PD are sometimes related to the NCSE, then sometimes it's not. So in other words, PDs are transitional state. So sometimes this PDs makes us very confusing to diagnose NCSE. So after CerebAair coming up, we try to see the validation of CerebAair. Where in my hospital neuro ICU, when from January to this July, who all consecutive patients with unexplained impaired consciousness, how we underwent CerebAair, followed by 1020 EEG monitoring. And we verified the concordance ratio of the 2 systems for detecting the PDs, RDA, SW, and continuous slow, and NCSE. So we use the intra-class correlation coefficients statistics to evaluate the validity of CerebAair and 1020. So in this period, 597 patients are admitted. Then 34 patients are candidates for this study. Finally, 31 patients are included. So median age is a 69-year-old, 61.3% is a male, median Apache 2 score is a 15, median 4 score is 10. So I'm going to show the easily on this slide. In this study, we firstly applied the CerebAair for several hours, then followed by 10-20 electrode session for several hours, then compared to EEG data. So this is the result. Result was shown in this slide. The kappa statistics showed highly value in PDs, kappa score 1. The other RDA and continuous low and non-converse status epileptics are 0.5, 0.65, 0.6 to 0.58 respectively. So our conclusion is PDs can be detected 100% with CerebAair, and CerebAair is a good, immediate, and easy accessible tool for screening of PDs. PD can be pre-stage form for NCSE, and therefore indicate a full 1020 EEGs recording if available. So from here, I'm going to show a couple of cases. So we will show representative case which CerebAair was useful. The patient is a 73-year-old and had a right acute hemadural hematoma, was pointed out. Here, then we evacuate the hematoma. Then after the craniotomy, you may see the very, very bad brain is seen. Then after the surgery, we will see we could see the subtle eye movement on this patient. Then we conducted the CerebAair for this patient. So this is actually exactly the photo which CerebAair was installed. Takes the guts and then start the monitoring. Then at first, at the beginning of the monitoring, we will see the PDs on the right hemisphere like this way, right? Then continuously the EEG has changed and time by time. Then next couple of hours after this, you see, this LPDs is more frequently appeared. Then we diagnose he is NCSE. Then treatment started. The next case is a 16 male, and he was transferred more than 5 minutes convulsions. At emergency room, he had presented restlessness, and he had no past history. Glasgow Coma Scale was E4, V2, M5. Actually, sorry, he is just an image. He is not the actual patient. Sorry, sometimes confusing. So. Okay, once seizure was ceased, but the patient did not wake up at all. What do we think about it? So we did a usual treatment. We should do within 5 minutes ABC stabilization, BS check, and within 10 minutes, benzodiazepine was intravenously administered, and the secondary therapy phosphate was loading intravenously. It's a usual treatment. Then, and also we did an examination. CT and the MRI was quite normal, and we have no finding of a stroke. And CSF seems to be look normal, but we suspectly he was probably encephalitis or something like that, so caused by unknown cause. So we treated with antiherpetics and steroid immediately. Then we will show the video. So this is actually the video EEG, continuous EEG monitoring in ICU. Oops. Number 2.
HTML2? No.
that's coming up, so we just skip. So in conclusion, we can see a bunch of bipeds. Then we treated with steroid and antiherpetics. Then also important things are administration of the adequate anti-epileptic drug with levetiracetam and valproate. Then finally those activities are ceased. Then after the clinical course, okay, it's okay. So after the course, the second therapy, levetiracetam, 60 milligram per kilogram, and the valproate is 30 milligram per kilogram, started, but EEG seizure continued. Then eventually we administered mitazolam and clonazepam, and they started, and then NCSE was finally aborted. So after 1 month, he discharged by himself, and currently socially independent, and he worked as an engineering. So again, if I use a metaphor on this iceberg, convulsive status epileptics is just the top of an iceberg. Huge amount of non-convulsive status epileptics are hidden in the huge ocean. So this is the final slide. I always tell the resident our mission. So to feel the voice of unconscious patients who are not able to speak and express by themselves. Thanks for your attention.
Yes, thank you very much for the nice presentation, and I think you have nicely shown the feasibility of the device, that it only takes a couple of minutes, and you don't need technicians to put it on the skull and the head. Are there any questions? Yes, please. The lady first. And
Thank you very much, Janne Born from the Netherlands. You have this organized very nicely, and you're very enthusiastic about it, and your nurses, who were lovely washers, they put it on in the evening hours. And I was wondering, who looks at it during the evening and the night?
Okay.
It's nice to register, but if no one looks at it, then nothing happens. So how do you have this organized?
That's a good question. So at the beginning of the starting monitoring, fellow can see the fellow in charge of the night. He or she is seeing the monitor, but so far, they have to do a lot of things in the night, even though at night. So far, in ICU nurse is monitoring the patient EEG. Then some changes happen. They called us to whether it's a PD or not or something.
So you have your team trained on
Yeah,
this?
exactly.
And then you can see the results from home. The continuous registration you can see when you go into your hospital system from your home.
Yeah.
Okay.
any other questions? Yes, please.
I have a question regarding your validation. You validated CerebAair with 1020 LED EEG, but it wasn't done simultaneously. So I was wondering, when you detect NCSE in your primary exam, you would have treated it, I suppose. You wouldn't detect it anymore at the second exam.
That's the limitation of this study. So at first, we are thinking about simultaneous monitoring. I mean, put the CerebAair, prior to the CerebAair, we put on the 1020, but it's so, devastating for patients because so many, electrodes on the scalp. That's why, so we just started the CerebAair, and but actually, so before the 1020 monitoring, we don't start the treatment in this study.
Okay, thank you. May I ask a second study that actually goes to Dr. Holtkamp? How do you feel as a neurologist when you see surgeons, intensivists, anesthesiologists analyzing EEGs?
So you're putting it on the political stage.
Like a cardiologist looking intensivist using it.
Well, I think the more you record, I think not everything can be seen and can be accompanied by a neurologist. And of course, we would like trained people, because the problem is you don't have scores. You don't have, EEG is not it's not for quantification. You need a little bit. You have to look at the EEG, and there's a little bit differences regarding the interpretation of the EEG, even among epileptologists. So when you show well-trained epileptologists 2 or 3 different EEGs, in particular from intensive care units, the kappa value is is not one. Yeah, there's some argument about what is epileptic, what is not epileptic, what is encephalopathy, and so on. So I myself, I'm used to work in a multidisciplinary team, and I don't have too many problems with this. But of course, I would like to see some standard regarding the interpretation of the EEG. And I think the questions you have asked are important. Who is looking at the EEG all the time? But it's always the problem. The more you record, the more is the question who is interpreting and looking at these data. And regarding your question, 1020 versus these 6 or 8 electrodes, when we do with the conventional EEG, continuous EEG monitoring on the neurological intensive care unit, we don't have 1020. It's too much electrodes. So we usually only have 3 or 4 electrodes on both sides. So the approach is very similar to what we are seeing here in the CerebAair system, but the difference is feasibility. It's easier to do. So I don't know what your experiences are. I think there's no need for 20 electrodes when you don't want to be localizing, but only want to look at diffuse brain changes. What is your experiences or your experience? Number of electrodes?
So we, as we said before, we're discussing before the meeting, in our department we have a specific situation where neurologists are much involved in the ICU, so we have 12 continuous EEG devices and we have 24 hours technicians available for EEG, even the weekend. So of course it's very specific, we have neurologists on call, but having said that, I think that as a neurologist, even if you're on call to interpret the EEG, you cannot be awakened the entire evening looking at all the abnormalities. So probably in the ICU we have to accept some limitation in what an intensivist or a trained person can look during the evening, accepting this limitation, at least because you want to avoid that clearly identifiable analysis, like for example, if the patient develops status epilepticus, if the intensivist is able to interpret quite easily the EEG patterns, then you can start a therapy in a proper way. You don't need prognostication at 2 o'clock in the morning, but in terms of intervention, that could be interesting. So I think we have to live with the limitation that intensivists are not neurologists, but you cannot do it 24 hours a day. I have maybe one question. So you basically work in the neuro ICU.
Yep.
And I think that maybe not all the people in the room here work in the neuro ICU. Have you tried to expand this approach to your colleagues in other ICUs? Are they interested to have monitoring in sedated patients or selected patients, ECMO patients, for example?
So far, we have no experience for the surgical ICU, other medical ICU. Just focus on the neuro ICU.
Okay.
Thank you.
Are there any other questions in this presentation? No, then thank you very much.
Thank
for
you so
this,
much.
And you want to continue?
Yeah.